Whoops, I guess I better unmute. Good morning. We'll go ahead and get started this morning with our Telehealth One-on-One Post-Acute Care Affinity group. We have a small group this morning, so we're going to just go ahead and breeze through a few things here and let us know what kinds of questions. We can keep it kind of loose and informal. So let us know what you have on your mind this morning. First of all, our little disclaimer, some of you have seen this a couple of times. We're trying to keep up with the regulations the best that we can. So hopefully this information that we're presenting to you today should be as up to date as we could possibly make it. If you have information that is more up to date than what you see here, please let us know. It really takes all eyes and ears out there to keep up with all of this. Everyone has been muted, so we are trying to escalate everybody, all the attendees, to a panelist function so that you can unmute and interact. So just be aware of that. This presentation will be recorded and sent to all registered participants, as well as any handouts that we review. Please enter any questions that you have in the chat box if possible. If you're just joining us by phone, you should be able to unmute at some point and ask us any questions you have. Please share your experience with the group. We are all learning this information together, so we'll try to make this as interactive as possible. So part of the structure of the affinity groups, first of all, is we have a regional health improvement collaborative made up of the organizations that you see here, various payers and professional organizations that are helping guide the affinity group work, and that also provide subject matter expertise in all of the areas of telehealth. The goal of the Regional Health Improvement Collaborative is to coordinate specialized knowledge, serve as a hub for communication, provide a platform to maximize the spread of resources, rapidly deploy telehealth technical assistance, and we gather to support the affinity group's needs. What is an affinity group? An affinity group is a group of people that have a common interest or goal and act together for a specific purpose. The purpose of this group would be to increase the capacity of healthcare providers and organizations, and in this instance, settings, post-acute care settings, in our region to quickly perform telehealth visits by offering access to subject matter experts, virtual peer networking opportunities, implementation tools, and resources. Our Mountain Pacific telehealth team that we have internally coordinating all of these efforts, our provider champion, Dr. Eric Arzubi, our HIPAA and security subject matter expert, Susan Clark, our technical expert is Deb Anderson, our billing expert is Amber Rogers, and our patient prioritization and workflow expert is Kristen Schuster. So we did do a bit of an evaluation as part of the registration process, and we have a couple of polling questions for those that are interested on today that are somewhat similar. So Tammy, you can go ahead and start launching that poll now. But we did find in the registration process that out of the 13 people that were registered, there were 10 that had done telehealth in the post-acute care setting previously, so that's great. We're hoping that those of us, or those that were not doing it before, can learn from those that were. So go ahead and complete the polling. We'll give you just a minute here. And I do have to say that unfortunately, our provider expert today could not make it at this time, so we will cover his material the best that we can. And it looks like the technology, UNISA technology, and access to technology, HIPAA compliance are on a couple people's minds. All right. Go ahead, I'll end the poll. Okay, so the technology piece, and and comfort with technology, that kind of makes sense, the setting that we're talking about. Our telehealth visit quick start list, these are just the 5 things that we outline as kind of the easiest, most straightforward way to think about implementing telehealth. The first thing is to choose your platform for your visits. Security, you would address security and provider considerations, and then any resident and family considerations here as well. Develop a priority patient list in this setting. It might look a little bit different than in the outpatient setting because you have some federal regulations that you're also trying to comply with. So resident interest and their ability would also be important, and potentially using some risk stratification. I don't know how prevalent that is in the post-acute setting, but we may be able to talk about that some here. Conducting your visit, essentially your workflow for that. How do you document the visit, and what are the legal considerations, and how do you bill and reimburse for the visit? So I'm going to hand it off now to Susan Clark and Deb Anderson to review the choosing a platform, privacy and security.
Thank you very much, Mary. My pleasure to be here today, and thank you very much for your time. My name is Susan Clark, and I'm the one that does the HIPAA and all things IT security. So as Mary mentioned, things are changing very rapidly this last couple months with the pandemic, and so we're just going to focus on the telehealth piece of that, but if anybody has any questions about HIPAA, please don't hesitate to reach out. But on the telemedicine piece of it, it's interesting that most of you on the call, it sounds like you're doing some telehealth, which is probably why many of you are answering that you're having maybe some trouble with the technology. It's a little difficult to use. So all very, very understandable, I guess, from our perspective. But so basically what happened was on the HIPAA front that there was some, there's waiving of HIPAA violations so patients can avoid travel, which is very important right now. And there's actually some platforms that you can use that kind of surprised me as an IT security, to be honest. These are platforms that you wouldn't normally be able to use. So I'm going to talk about a few of those. And then my colleague Deb Anderson is going to take it over from there. So of course, you're always encouraged to still use a HIPAA compliant service, but we have a few options just in case those aren't available to you. So Mary, if you could do the next slide, please. So this is a worksheet that we did. Basically, it's a security analysis on some of those platforms like FaceTime and Skype and Teams. Again, these are not telehealth platforms and not platforms that you would normally use for telehealth. They do have some level of security built in, and so we wanted to point that out to you just in case. Like I say, there isn't other options at this time. You can definitely take a look at these. And to get some of those security pieces, you actually need to have sometimes you need to have pieces of it turned on. You know, for example, you have to have private conversation if you're to do a Microsoft Skype. So this is something to be aware of. If you're interested in this, this is actually on our website, this worksheet that we did and pulled together, and hopefully it'll be helpful for you. Like I said, if you're not, you know, if there isn't any other option. And we actually are calling this patient friendly because, as we know, a lot of folks like their iPads and are very comfortable with them. So this might be some technology again to kind of get you over the crunch. So just wanted to make you aware of that. And then I'm going to pass it on to Deb Anderson to talk about other platforms that might be more suitable. So with that.
Thank you, Susan. Good morning, everyone. We're so happy you could join us today. I'm going to talk a little bit about choosing telemedicine software because what we would really like to see is that the toothpaste never goes back into the toothpaste tube, and that the things that we can select and implement and utilize are things that we'll be able to continue to use after this public health emergency ends. So it's interesting, you know, every setting, every practice, every person has some of their own ideas and some of their own preferences. So when you're thinking about what to choose, hardware or software, you know, you need to consider who's using it, how they're using it, when they're using it, where they're using it, and then choose wisely. It is, you know, obviously we have the opportunity to talk to a patient and see if they have any experience with using FaceTime or using Skype or something else that they have, been comfortable with in the past. And I think that truly opens up the door to move us towards something that's maybe a little bit more standardized and accessible to the patients and the providers specifically. Next slide, please, Mary. So for me, when I think about what we need to use, we may have providers using multiple devices. Some may have their iPhones, their iPads, but they also might have a Windows laptop. How are we going to use it? Is it going to be available just within a facility that has a wireless Wi-Fi connection where we have to connect to their network? Or are we going to maybe utilize some cellular technology where that particular smartphone or iPad can travel anywhere and still have connectivity to utilize the tools that we're talking about? Again, I think it needs to be easy to install, both for the provider, for a patient family. I think one of the things that I've really like to see now is that as we're using Zoom, a platform like what we're on right now, you can invite multiple people. So maybe mom's isolated at the nursing home, and there are 4 brothers all around the country, and there's a daughter that's in Sheridan, Wyoming, and we want to connect everyone. So everyone needs to know that they're able to utilize this on their device, and also that it's easy to install if there's an app that needs to be installed, and it's easy to open. And obviously, especially for our patients, it's easy to use. One of the other things when you talk about easy to use, I have been doing a little bit of research, because one of the things we see, one of the things we hear a lot are the accessibility issues, the ability for the patient or the resident to actually hear someone. So things that you might want to consider if you actually have a setup within your facility is it should have speakers that you can increase the volume, and or there are translation services where you can use Microsoft Translate to take the voice and put it into text while there's a visit going on with the provider and or the family. So think about the special things that you might need to truly accommodate and have a good experience, because honestly, the better experience we have to start off with, the better it's going to be for our residents and our standardization and our implementation of this down the road. Next slide, please. So again, not only does it need to be accessible, but it needs to be reliable. And when you're actually looking for a platform or a service, HIPAA compliant, Susan will tell you it's something that we need to make sure we can have a business associate agreement with that vendor. We need to make sure we understand the security implications and settings as we move forward. But also, we need reliable internet services. We need reliable devices. So again, think about the entire gamut. And I'm also saying, plan for your backup. If FaceTime is something that you've maybe been able to utilize with the families and with the residents, keep that in your back pocket for a backup when some of the other systems, like maybe a Zoom platform goes down, or maybe the one through your EHR goes down. Have that contingency plan in place. So it's interesting, some of you have put that you have technology questions, and I'm thinking that we'll probably have time at the end of the session, so please be sure and put some of those questions in the chat box, or be sure and bring those up for us, and we can look into those and see what information we can find to help you. And speaking of that, I think I see a few things in the chat box. And okay, Mary has reminded me there are funding opportunities. So for those of you who haven't heard or haven't seen, in several of our states, there are little mini grants that are available, $3,000 plus or minus for some of our nursing homes, long-term care facilities. There's also FCC funding. There's going to be additional USAC funding. I think we have an actual funding subgroup under this Improvement Collaborative, and I've got a meeting with the folks from Wyoming. We did meet with the folks from Montana. So if you are concerned or looking for some assistance or looking for some funding, please don't hesitate to reach out. Right now, there are some issues around funding for skilled nursing facilities, but not necessarily for long-term care. I think that will change, just like we saw things change around the billing, as we continue to move forward. So thank you, Mary, for reminding me of that. I think that might be my last slide.
It is. Thanks, Deb. And if you need any help with
Certainly.
those funding things, please reach out. Civic, I was helping a couple people last week with some of those small mini grants. So please reach out if you need assistance with those. And some of the smaller ones are coming through the Department of Health and Human Services. So let us know if you need more information there. So engaging residents and families, this piece is normally covered by Dr. Arzubi, and he talks about his visits. So I'm not going to be able to cover the material the way that he did, but I would like to hear, I know that April and Deb Jorgensen and Liz registration, and you had indicated that you were all utilizing telehealth in your facilities. And so I was wondering, we fixed things so that you can unmute and speak. And I was wondering if you would share, since we have such a small group today, if you would share with us how you are successfully engaging your residents and families in your telehealth visits. Otherwise, I would just say that I know Dr. Arzubi talks a lot about, some of the technical aspects of it that Deb kind of covered, making sure you have robust internet. And I don't know, I'd be interested to hear from you as well, how that's working out in your facilities. If you were wired for this prior to COVID-19, or if you've had to expand some things since starting up. He also talks just about lighting in the rooms, which also might be a bit of an issue in some of the resident rooms, and sound. And of course, Deb mentioned making sure that your residents can hear what's going on. One of the conversations I had with a facility last week was that they maybe needed different types of equipment. Maybe laptops worked better than tablets did, just because sometimes the residents or that they needed to have some typing capability, or the families needed to have typing capability because the residents could see better than they could hear. So maybe they could look at questions or read things on the screen better than they could hear what was going on. So feel free to jump in if you three have anything to share, or if any of the other staff on the call have seen some things that are working well.
Mary, I'm wondering about headsets for the residents.
Oh, headsets.
Yeah. I know that's why I use them. So it is much easier to hear with a headset. So
there you go. So that might have solved that problem from last week. I might have to email that gal and let her know.
Yeah.
So then prioritizing your patients or your residents, we worked on and have seen where face-to-face, the regulatory face-to-face visit can now be performed by telehealth. So I think that's probably where I've seen and heard from facilities where they're starting to use it more often. I think that, what Dr. Arzubi would say is that identifying your patients and your residents that really need to see a provider is no different than any other time. If they need to be seen for something, whether it's over a televisit or when it was in person, that it's not different, that those criteria are same. And thanks for chatting in, Deb. Laptop has worked well. The main problem is you don't have a dedicated laptop. Been using yours, and headsets are a good idea. So Deb, you might look into some of that funding because I know that's what I was helping a facility with last week, because they did not have enough laptops. They had about 60 residents and they only had one, and they were trying to get a few more laptops, and they were also trying to get a wheelchair accessible table that they could roll the residents up to. a little bit better. So there was a special table that they were looking into as well. So that's great. Liz, go ahead.
Yeah, so we found that tablets work really well for telehealth visits. The biggest thing that why we chose to use tablets over a laptop or a desktop computer is tablets can be easily moved around, so the visits can go to the patient's room, and then you aren't having to bring patients back and forth, contaminating through the hallways. Also with the tablet, it's easier moved around, so if the physician you're telehealthing with needs to see like swelling or wounds or things like that, the tablets are much easier to move around so people can see that better.
Are you doing a lot of your regulatory?
Oh yeah, we're doing several telehealth visits a day.
And how big is what's your size of your facility?
I think we're licensed for up to like 190 beds, but our census is in the 140s right now. So we're doing telehealth visits every day with outside physicians and our what's usually our inside physicians. We've been doing telehealth completely for a few weeks now. So we have every day with one of our physicians that used to be in-house, and usually see 4 to 5 people a day on those ones. And then we've gotten set up with WMC and everybody else. So if you have any questions,
Deb has a good question. What's that?
If you have questions, I've set a lot of telehealth up in our building. So
yeah, Deb Jorgensen has a question in chat. Do you have someone who stays with the resident in the room during their telehealth visit? Says they've only been doing that if the resident requests.
So yes, because some residents, it's kind of hard for them to hold that tablet, and they have a struggle with it. We always have the nurse of that resident go do the telehealth visit with them, because then because they are the best person equipped to handle the questions if the physician has any. They help relay the information back and forth between the physician and the resident if they're struggling with hearing or anything like that. I have a nurse.
Good deal. Have you had to increase your staffing to help with telehealth visits? I'm just curious.
No, what I've done to help that is we have our med times, and so we try really hard to schedule our telehealth visits in the in-between times and not during a med pass. And we pre-warn our nurses as far ahead of time as we know that they're going to have a telehealth visit coming their way, so that they can plan that in their day.
And I've heard actually from some that the telehealth visits have helped with provider and staff interaction, just because providers used to kind of come in and do their visits, and you may or may not know that they were there until they've charted. Are you guys experiencing that it's kind of helping with that, or?
It is. One thing that I really like about it is, if we have a resident that's having issues and we need to make sure it's addressed, like you're saying, you don't know, oh, did they come see that person? Oh, here's a note on them. I had no idea they were even here and saw them. Now we know that those issues are being addressed and when they're being addressed. So that is kind of nice. And then, I think things that probably slip through the cracks sometimes probably are not, because each nurse has the physician right there in front of them, and they're like, oh yeah, while I have you here, I've got this going on with this person. So I see more things getting addressed with the physicians.
Good. Kind of a unintended side benefit.
Yeah.
Yeah. Great. Well, thank you.
Yeah,
and feel free to jump in as we go through things. And
I'm gonna just tap Deb for a minute too, if that's okay. So I like the tablet too. So I'm kind of curious what software you're running on the tablet.
So we have iPads that were provided by our corporate, and it's been a lot of fun. But I've gotten we are running Skype, FaceTime, Zoom, and WMC's preferred choice, In Touch.
Yep, I think that's perfect. That's perfect. That would have been my choice too. So very
So we're
good.
also doing all that because so now the families can also, we have a wide variety, and families can also video in just to visit with their residents.
Yeah, I think it's perfect. And I use my 90-year-old mother because she has an iPad and she does all those things. So I think it's great. It's great because you have one device that has several functionalities. But so, and it's pretty easy. Yeah, and I find a lot of seniors like the iPads. That's just my experience. But.
So far, I have two.
Yeah, we did have another question. If there's a document that needs to be signed to say the resident's okay with the nurse taking part in the visit, Amber responded that consent doesn't have to be a specific document, that verbal consent is fine. I would just back that up with, as long as you've documented that you got consent. It should
Yes,
be.
and then there is a telehealth consent form that is on the Department of Health's website
Mhm.
that we had all of our residents sign and give verbal consents to, so that we had documentation that they were okay with seeing their physicians through telehealth.
I think too, she was asking if the resident's okay with the nurse taking part in the visit. Do you have any
A lot of our
other-
residents are just fine with it. I haven't had anybody complain. They actually enjoy it because the nurse comes in with the technical side of things, and the doctor gets a more thorough picture at what's going on with them.
And Deb, that is perfectly okay. That falls under TPO, under HIPAA. And really, I think it's a great idea too, because I mean, the nurse can check the chart. So, you know, if they're not there, they can still, you know, get that information from the chart, but they're certainly fine to be there. And I do like what you're doing with the consent form. And this is something that I think, you know, you just got everybody to sign it. And just make it part of your practice to have that line in your consent form, and then you're good. Then you don't have to worry about it at every visit. So I think you did that very smart.
We do. Upon any new admissions we've got, that's part of our admission packet currently, is to go over that consent form. And
yeah, and that's what I recommend to clients too. I think that's perfect.
Right, good deal. So resident interaction during the session, Dr. Arzubi highlights that eye contact is very important in making sure that you know that you should look into the camera. You know, and sometimes this is more education on the provider side as far as they're interacting with the residents, and then checking in with them during the visit to say, how is this working with you? Even your nursing staff, you know, could do that, or they'll be more in tune probably with the resident and how well it's working or if it's not working. But if you have other people joining the visit, just checking in to make sure that, you know, the brother and wherever, if they're having any technical difficulties and things like that, making sure that things continue to work for them throughout the visit. After the session, just talking to them about how things could have maybe been differently and done differently to make things go smoother if there were issues, any lessons learned, and additional bugs that need to be fixed. Documenting the visit, if you have EHR processes, like considering to build a template to streamline your process in your EHR, or at least maybe just making sure that it's identified that it was a telehealth visit. If you have your consent, then the consent form is signed. The location of the resident and the location of the provider are important things to note. Originating site and distant site kind of goes into that as well. Some of the legalities, method of connection, so, you know, kind of even mentioning what platform was used, making sure that the provider and the resident were both identified appropriately, a statement for resident consent, either verbal, that it was verbally obtained, or the other one, I think we've covered that. If appropriate, how to access face-to-face care if there's an emergency. This is maybe more for your assisted living facilities, that kind of thing, that was addressed during the visit, especially if they're just visiting with a resident and they're outside of a nursing home or something like that, and it's just resident to provider. The provider would want to mention how they can access face-to-face care if they have an emergency. And then the typical documentation, you know, the other thing Dr. Arzubi always highlights is that this shouldn't be that much different than a normal visit. What was the length? What did you do? What was your assessment? What did you find? What did you find out? And what was your plan of care as a result? So not getting too far from the normal, you know, required documentation just because it's not a face-to-face visit. So I'm going to turn it over to Amber to talk about the billing piece. But the telehealth consent form, I see your question. I see Amber did too. So we'll follow up, Deb, and make sure we can get that telehealth consent form.
Yeah, it'd be kind of nice to have that all standardized. I was just Googling as we were talking, and I was like, well, I don't know if that's the right one or.
Yeah, and I know AHRQ came out with one as well. Liz, do you have one that you're specifically?
Yeah, I'll go look for it and post the link to it.
Awesome, thank you.
This one's from the state Medicaid.
Okay.
So
yeah, I know there's a lot of sources out there that are providing different things. So it's, yeah, be nice to see the one you're using. Thank you. All right, Amber, go ahead.
Yeah, so just like, you know, your visit should still cover all the medically necessary things that need to be covered face-to-face, the same thing is true with billing. So the only thing that, go ahead and move to the next slide. So the only thing that really changed was the fact that the in-person visit can now be done, you know, via telemedicine. So they released 80 plus codes that could be done via telehealth that previously only were allowed in person. So these all included home health, hospice, and nursing homes. So that is just awesome. And it can be both the initial, the subsequent, or the discharge date can all be done via telehealth. Now, the interesting thing about the telehealth codes for long-term care and home health is that those cannot be done by audio only. When they first came out with the relaxation of the rules, they made a very clear distinction between telehealth, which is the real-time audio and visual, and then the telephone codes. They then later on revised the usual office visits that could be paid for at the same rate with a telephone visit as a telehealth visit. However, that relaxation did not occur on the telephone visits for the post-acute setting. So you still do need to make sure that you have that interaction with both the visual and the audio. There's no reason why a provider couldn't bill a telephone visit, but it's just probably not as appropriate with this higher risk patient that we have in these settings. Next slide. The CPT codes all remain the same, and I'm just gonna throw those in chat. Those are all the codes that the providers use. So those are the same. You use the same thing, you bill the same thing. However, you do need to bill, I think it's the next slide. The place of service is what it would have been if it would have been furnished in person. So in this case, it would be the facility code of the nursing home. And then for Medicare, you add modifier 95. We're really only kind of keeping up with the CMS regulations. I know that the Medicaid might have you bill the modifier of 02 for the place of service. But still you would keep the modifier 95. There we go. And so that's, and the nice thing is that all of these are now paid at the same rate, you know, in person versus, you know, versus telehealth. So that's just awesome. So we do have our 4-state region. We looked at the various Medicaid rates are all the same. All of our states are at parity. None of them allow the Facebook Live or TikTok, not that people in that age group necessarily are probably TikTok fans, but you never know. And then you can see that the place of service is the O2. Next. I guess that's any questions about the billing? Have you had any claims rejected? Any issues with getting those through? No news is good news.
Might be too early to tell yet.
Yeah, it probably is actually.
Okay, and I see Liz shared that consent form. It is a Wyoming document. So Deb Jorgensen, I'm not sure what state you're from, but let me know if you need any other state-specific help. And if you guys have, we'll save some time today. It's a small group, so we were able to get through things pretty quickly. The information that will be shared today, there's a telehealth checklist that Susan put together that reviews if you would like to continue telehealth, maybe in a little bit longer term. Can you see this here? Can you see the checklist now?
Mm-mm.
Nope. Sorry, let me. So this checklist is for some rapid deployment. It kind of really just outlines very quickly all of some of the things that we've discovered. If you've already implemented telehealth, there's some things to consider if you're looking for a temporary solution, and then if you're looking for more of a long-term solution. So this checklist will be sent out to all of you as in addition to the vendor list that that Susan talked about earlier as well. So that right here, it's a little bit small, but we'll send that out to you as well. So we will move that. We do have a telehealth specific website that is up and going now. So we will put any resources that we gather from people there, and as well as if there's a place to submit frequently asked questions and answers. And then there's a bunch of FAQs as well on the website. So links to our partners, information about funding, pretty much everything is there. Amber, would you just put that website address into chat for the group for me? And feel free to use that website at will. Marcy is asking if Montana could use this consent as well. I think maybe we'd want to have Susan take a look at it and make sure there aren't any state-specific things that we'd want to consider. Susan, would you be interested in that? And Susan just put some more consent information in as well.
Yeah, I've been delving into consent quite a bit, Mary, so I'd be happy to do that.
I know.
And
that's why I was like, well, good question for Susan.
She might know something. Yeah, I'd be happy to. Thanks.
Thank you. Okay, so we just outlined a couple of next steps. I know most of you on the call have started already doing it, but be sure to just start where you're comfortable, move forward where you're comfortable, where your residents are comfortable. And if needed, you can schedule a coaching call with one of our team members, depending on, kind of what struggles you're having. Maybe you need more technical assistance or some information on privacy, security, or billing. Don't be afraid to reach out. We can help you out with that, and be sure to share with us any of your progress or speed bumps at our next session. We are going to push out the next session to June 1st, where we'll talk about kind of fine-tuning your processes. So We look forward to meeting with more of you then, and then we'll kind of gauge the need for continued sessions, any kind of group activities or peer-to-peer network sharing that any of you would like to do after that. So that is essentially our presentation for today. Like I said, this will be recorded and the slides will be sent to you, so you'll have everyone's contact information should you have some more questions about any of these items. But we greatly appreciate your participation today, and we'll give you about 15-20 minutes back in your day, which I'm sure everybody could definitely use on a Monday morning. Unless you have any other questions, feel free to speak up or put them in chat. We'll hang on for just a few more minutes. Okay, I'm not seeing any more questions, so we'll go ahead and officially end the session, Tammy, and thanks everybody.
Thank you.